Today I want to talk to you about cardiovascular disease prevention, mostly focusing on primary prevention. As we know, there are various international guidelines that have been developed focusing on risk assessment as well as primary and secondary prevention for cardiovascular disease. Unfortunately, none of these guidelines are based upon or maybe appropriate for South Asians and especially Indians. I am sure you are aware that Indians have one of the largest incidence of atherosclerotic cardiovascular disease manifesting as coronary artery disease or cerebrovascular disease or peripheral vascular disease. The causes of these are multifactorial. Some of it may be genetic, some of it may be diet related, some of it may be related to the development of lifestyle diseases such as diabetes, which also we know India is the world leader in. Having said this fact that the guidelines that are available today are multiple and confusing, have got different levels of recommendations, and none of them are addressing the pressing fact that our population develops atherosclerotic disease at an earlier age in a more aggressive fashion, and they have more extensive disease than maybe anywhere else in the world. There is a need therefore to develop urgently appropriate guidelines for the prevention as well as prognostication of this disease in Indians. And to this end, the Lipid Association of India, which is a group of so-called cardiological as well as metabolic as well as internal medicine experts, have got together and tried to make a consensus guideline based upon inputs from various international guidelines and which are Indian centric. I felt it is worthwhile to discuss this with you today so that we may more intensely focus on prevention of this major lifestyle scourge that is afflicting millions of our countrymen at a relatively young age. To this end, there are certain risk categories for development of cardiovascular disease that have been laid out, and these are laid out because the targets to achieve in these patients or in these individuals for the lipid fraction of LDL or non-HDL are different and appropriate to the risk. These are more aggressive than the currently accepted international guidelines, but as I mentioned, this is probably appropriate for us, and there is no evidence as yet that trying to achieve these targets may be harmful to our patients. So when we are trying to do some good for our patients and prevent the development of this disease, we know that the best preventive therapeutic way of apart from lifestyle modification is to reduce the LDL and non-HDL fractions in the patients so as to achieve, which is the most appropriate way to reduce their cardiovascular risk. To achieve this goal, various targets have been granted or have been given to the risk categories of patients. There are 4 risk categories that have been devised in these guidelines: very high risk, moderate risk and low risk. And for these, the appropriate levels of LDL and non-HDL cholesterol have been laid down. For very high risk, the LDL goal is 50 or less than 50 milligram per deciliter, and the non-HDL, as we know, is 30 milligram per deciliter higher, that is 80. For the high risk category, it is 70 or less, and the non-HDL cholesterol is 100. For moderate risk as well as for low risk, the LDL goal remains less than 100, whereas the non-HDL goal remains less than 130. In these guidelines, the risk factors, there are 3 categories that are divided. Those are which are the conventional risk factors, The second are known as other high risk features, and the third are known as non-conventional risk factors. The conventional risk factors that are considered in these guidelines are age, more than 45 for males and 55 for females. A family history of premature coronary artery disease, which is again defined as CAD occurring in the first degree relative at an age less than 45 in a male or less than 55 in a female first degree relative. Third risk factor is current tobacco use. Fourth is hypertension, and fifth is low HDL. I have told you the division of the risk categories of patients and their appropriate levels of LDL and non-HDL cholesterol. Now, how do we define these risk categories? The first is the very high risk category, in which the LDL target is 50 and the non-HDL target is 80. These are patients who are defined as already having some features of clinical features of atherosclerotic cardiovascular disease, A. B. Diabetes with evidence of end organ damage or with 2 or more major risk factors, or 3. Patients of familial homozygous hypercholesterolemia. What are high risk group? High risk patients are those who are defined as having a 15% or more risk of having an event or dying from cardiovascular disease over the next 10 years. These are defined as, that means these are patients who do not have disease but are at high risk. Who are these patients? They are defined as having 3 or more of the major conventional cardiovascular risk factors. These risk factors are the standard ones. They are defined as increasing age, more than 45 for males and more than 55 for females. Family history of premature coronary artery disease in a first degree relative, more than 45 years of age if male and more than 55 years of age if female. Current use of tobacco, hypertension on medication, and fifth, low HDL. So these 5 conventional risk factors are taken into account. So this is one category in high risk. The second category is diabetics with 0 or 1 major risk factors and with no evidence of target organ damage. Next, advanced CKD, that means at least stage 3 or more. Next, familial hypercholesterolemia, which does not include those in the previous category, that means those without familial homozygous hypercholesterolemia. And the last is extreme of one single factor. For example, LDL of more than 190, very strong family history of premature coronary artery disease, or heavy smoker. So these are also included in the high risk category. In the moderate risk category are included people who have got 2 or more major risk factors, as I have detailed earlier. Now, in this, certain non-conventional risk factors should also be taken into account. Those who have, for example, on CT, if they have a coronary calcium score of more than 300, they are considered to be included in the high risk category. If they have a carotid plaque which is non-stenotic or non-severe, it is an indicator of high risk. And those who have lipoprotein little a of more than 50 are also included in the high risk category. In the moderate risk category are included those who have a coronary artery calcium score of more than 100 but below 300. Those who have increased carotid intima medial thickness or IMT but without a stenotic plaque. Those who have a lipoprotein little a of more than 20 but less than 50. Those who have got metabolic syndrome. If these exist in a patient even without the conventional risk factors, they may be included in patients with moderate risk, which means they have a 5 to 15% risk of developing a coronary or cardiovascular event or dying from one in the next 10 years. Low risk patients are those who have got a less than 5% risk of developing an event in the next 10 years, and these are included anyone who has got 0 to 1 major risk factor. So this is how the categories of patients are defined, and this is how the level of, based upon the level of risk, the level of aggression to reduce the LDL and non-HDL cholesterol is given in these guidelines. Another notable fact which separates these guidelines from the most recent ACC guidelines which came out in November 2013 is that targets are given which seems to be easier or better for us as physicians, where we have something to aim for in a particular patient. Of course, the caveat or rider in these guidelines is that all these have to be discussed with the patient. The levels of doses required of drugs needs to be explained to them to achieve these goals, and with their cognizance and with their consent, and the physician and the patient have to partner in achieving these goals. Clearly, side effect profile and other issues have to be addressed on an ongoing basis and are topics which need discussion on their own. So that's all for today. I think I would like to end by saying that our population, which is at very high risk for developing cardiovascular disease, deserves guidelines which are tailored specifically for us, so that we may prevent this problem from overwhelming a generation of our countrymen. Thank you. Jai Hind.